All right. The second part of this lecture is basically a discussion on cardiomyopathies. So at least you have an idea. This is actually a little bit more than the book has made it out to be. The good thing is that it's rare, so that's why the book doesn't go into a lot of detail on it. But unfortunately, some of you have to sort of understand at least how to deal with it, because it does come through every once in a while to the operating room. There's two kinds of cardiomyopathies. You have primary cardiomyopathies, which are confined to heart and muscle, okay? And then you have secondary cardiomyopathies, which could be infectious diseases or anything that affects multi-organ systems, okay? These are the much more serious ones that you have to deal with. But even whichever one you're dealing with is a cardiomyopathy, means you have a low ejection fraction, and a lot of times with a dilated heart, and you have a big problem with your hands when putting these patients under anesthesia. The primary cardiomyopathies could be from three different kinds. You can have genetic, mixed, or acquired. The genetic abnormalities could be from things like the DNA improperly producing the actual proteins for the heart function. So you may actually develop a hypertrophic cardiomyopathy. You may also get arrhythmogenic right ventricular cardiomyopathy, left ventricular non-compassion, glycogen storage diseases, okay, which is you start accumulating too much glycogen inside the heart, and the heart basically becomes have not enough space for the actual the contractile component of it. You may also get conduction defects, and you may also develop ion channelopathies, which lead to long QT syndrome, Brugada syndrome, or short QT syndrome. Okay? These are all significant arrhythmias that can cause and lead to cardiomyopathies as a consequence. The mixed are dilated or primary restrictive. Okay? The acquired are things like myocarditis, which is inflammatory cardiomyopathies. You can also get viral, bacterial, such as, or parasitic, like Chagas disease. And then you can have a stress cardiomyopathy as well, or peripartum cardiomyopathy. We deal with a lot of primary cardiomyopathies that are actually related to pregnancy. Okay? And those can be really scary. Okay? When you have a patient comes in on the day of delivery and the heart rate's like 140 on the woman, don't blow it off. Okay? And don't think about putting an epidural on that person until you figure out why the heart rate's 140. Okay? I had somebody, I asked them the other day, they called me up and said, oh, we got a heart rate of 140 in this lady. I said, okay, well, does she have a fever? No, which is the reason why the heart rate could be up. Does she have choreo, which is an infectious source? That also is a sign of sepsis? No. No other symptoms at all. I said, well, has anybody listened to her heart? No. Okay. So I went over there, helped, listened to her heart. She had a huge MR murmur. Okay? And that's a bad sign, because that's a sign of usually a dilated heart. Okay? You always have a certain degree of MR in pregnancy because the heart does dilate, but when you hear it like wide open, that's bad. Okay? You should hear it like, it's a little bit of a very low hum, and that's normal. Okay? But when you hear it really grossly evident, we did an echo on her. Her EF was down to 5%. Not good. Okay? So that lady went right to the operating room and got a general anesthetic, believe it or not, and then immediately removed the baby without stressing her with a normal vaginal delivery. She wouldn't have tolerated the vaginal delivery. And as soon as we got the baby out, she went into failure, which that was not a big surprise, okay? Because what happens to the volume when you take the baby out? It increases even more. So having positive pressure actually helped us. We gave Lasix, Diurestor, did a TEE on her. She looked like she had EF improved from 5 to about 15% by the time we were done, because we Diuresed her tremendously, and then we extubated her within the next day. So she did fine, went home eventually. Now, do they do fine long term? A lot of times it's just related to the actual hormonal milieu of pregnancy that induces a cardiomyopathy, and it goes away. Sometimes it doesn't, so that person needs to be followed up by a cardiologist. I don't know what the long-term effects on her so far, but I do know we got her extubated in the ICU and she was doing better. So hopefully she'll do fine. Secondary things are a little bit more involved. You can have infiltrative, storage, toxic, inflammatory, endomyocardial, endocrine, neuromuscular, and autoimmune. So these are multi-system disease problems that affect the heart. If you look at infiltrative, things that will be proteins or other things that are not supposed to be going into the cells, things like amyloidosis. Okay, amyloid is a protein or complex that actually gets deposited inappropriately and starts affecting the actual myocardial contractility. You can have also storage diseases. These are usually genetic disorders. They can also cause significant problems with neural development as well. Things like hemochromatosis, glycogen storage diseases, and human Pick's disease. Toxic reactions can also occur, especially for chemotherapy drugs. So people that are on doxorubicin, okay, or cyclophosphamide are also very high on your list for worry for developing secondary cardiomyopathies. And we actually get MUGA scans before we do, and adriamycin is another one that's really high on our list for this as well. You can also get lead and mercury toxicity from heavy metal toxicity, leads to a cardiomyopathy. Inflammatory diseases such as sarcoidosis, and then you may actually have endomyocardial, like hypereosinophilic Loeffler syndrome, and endomyocardial fibrosis. Okay, just want to know that there's lots of different causes. I'm not going to go into all of them. The other one that's pretty high on my list too is this one, autoimmune diseases. Lupus can also kill you very quickly by inducing a very severe cardiomyopathy. Young women can get this much more frequently than males. Okay, so it can be the devastating complication in a very young woman. What you see is there's different forms of dilated cardiomyopathies. Okay, this one's a normal patient. Okay, and this is a person who's got a dilated cardiomyopathy. Okay, you may also have the hypertensive cardiomyopathy, where you have, hypertrophic cardiomyopathy, where you get enlargement of the heart, and then you have, which is this one is called restrictive cardiomyopathy, where you get increased scarification inside the ventricle, and the ventricle is unable to relax. So there's different forms of these kind of cardiomyopathies. Okay, so I just wanted to walk you through them. Okay. The hypertrophic cardiomyopathy is the most common form. Okay, it presents with hypertrophy of the septal-anterior lateral wall. It can basically result in almost like a very similar symptoms as IHSS. So you got to treat it pretty much like that. Okay, you need to give it adequate filling time, so patients become much more symptomatic when you actually empty the heart. Okay, so anything that empties the heart in hypertrophic cardiomyopathy, you make the patient worse. Okay. And also they also have diastolic dysfunction, which is they have prolonged relaxation phase and decreased compliance. This is a nice picture showing you how much extensive remodeling occurs in this kind of cardiomyopathy. Okay, you can see how thick the ventricle is. Now, events that increase outflow obstruction or increase myocardial contractility. So giving these people catecholamines makes them actually worse. Okay, so beta-adrenergic stimulants such as epinephrine or isoprosternol will actually make this person worse. DIG actually makes it worse as well. Things that decrease the preload will also make it worse, so this is not the one you want to treat with if you have a hypertrophic cardiomyopathy, okay, without left ventricular outflow obstruction. Vasodilators as well, which decrease the afterload, will also make the situation worse because you empty out the left ventricle. So basically this begins to act just like IHSS. So as long as you remember that, how to treat that, you know how to treat this as well. If you decrease the afterload, it also makes it worse. Okay? Events that decrease the outflow obstruction or decrease myocardial contractility, such as beta blockers, volatile anesthetics, and calcium channel blockers. Things that make it slightly better are increased preload. Okay? So give more volume to that patient. Slowing down the heart rate also allows the ventricle to fill better, so you get less of the outflow obstruction. And then also increasing the afterload actually is better for these people because you prevent the volume to leave the ventricle, and as a consequence, they seem to do better. So alpha adrenergic stimulants also help. This is what you see. Okay, this is a nice echocardiogram. I wish I had it under a loop to show you. But what ends up happening with this kind of cardiomyopathy, hypertrophic cardiomyopathy, is that the septal wall begins to touch the mitral valve here. Okay? And that mitral valve basically then impedes the forward cardiac output going out to the outflow tract into the aorta. Okay? So you can see how the left atrium, the mitral valve here, okay, begins to obstruct the outflow tract going up here. Okay? That's an outflow tract obstruction. Hypertrophic cardiomyopathy is myocardial ischemia. May also develop normal coronary artery disease. Okay? It leads to an increased left ventricular end diastolic pressure due to compromised coronary perfusion, and Decreased diastolic filling time would make the situation worse. Increasing oxygen consumption due to hypertrophy also makes the myocardial ischemia much worse. And the presence of metabolic derangements in the oxygen cellular levels can also cause this problem as well. These patients will develop dysrhythmias and may actually cause sudden death. Diagnosis is usually done by EKG. By looking at EKG, you see a left ventricular hypertrophy by increasing your QRS signal. Echocardiogram is by far the best way. Treatment, okay, is that if the person doesn't have any mild or no symptoms, no real treatment, or he considers drug therapy early. Okay. If the person is high clinical or genetic risk of sudden death, amiodarone or implantable defibrillators. We don't do long-term amiodarone as much as we used to, and that's why. What happens to the patient's skin? They turn blue. Okay. So that's not good. Okay. Heart failure, if the patient has got the obstructive versus non-obstructive, it's completely different. If it's a non-obstructive, continue drug therapy if responsive. If not, then you consider doing a transplantation in that patient. For obstructive drug therapy, you got to be careful because that person, if you preload reduce them and have problems with that, you're going to make the obstruction even worse. Pharmacological therapy is basically to improve diastolic filling time. The better, the more time in diastolic filling, the better. Reduce the left ventricular outflow obstruction the best you can. Decrease myocardial ischemia, and drugs that are effective for this is beta blockers, calcium channel blockers, and amiodarone. Surgery is sometimes used as well to remove the hypertrophy causing the outflow tract obstruction. It's considered in only approximately 5% of patients who have marked outflow obstruction and severe symptoms unresponsive to medical therapy. So there's considerable risk with this procedure, to say the least. Minimize your left ventricle. We already went through all this, so I'm not going to go over it. Just make sure that you don't increase contractility. It's going to make it worse. Maintain adequate preload, and don't drop off your afload and make the situation worse. Okay. Regional anesthesia may actually make the person worse because it drops preload and drops afterload at the same time. So regional anesthesia may be something you may not want to consider doing because you may actually make the outflow obstruction even worse. Okay. General anesthesia seems to work fine as long as you're careful in the sense that you don't give excessive positive pressure, because then you can impede positive preload return significantly, and then you get into worse problems as well. Dilated cardiomyopathy is what most people think about when they're looking at cardiomyopathies, but it's the second most common cause. Okay? What you see is biventricular dilation or left ventricular dilation. You get systolic dysfunction because the ventricle begins to dilate, and you're over the top portion of the Starling's curve. And you can sometimes see it with almost normal LV wall thickness, but it's just dilated. Okay? This is, you can see how dilated the heart is. Of course, this is a pathological specimen. Things that can actually induce this are things like alcohol, cocaine, and we see this a lot in our population because not so much the cocaine, but from the alcohol use. Chronic long-term heavy dose of alcohol, you're doing a whole quart of vodka a day or something like that, you're going to burn out your heart. You can also see it from peripartum state, which is the other place where I see a lot of this. More rare disease problems are pheochromocytoma. The other thing that I've seen here as well is Chagas disease from a patient that was from Mexico. And I don't think she was Mexico, she was from Central America, from Salvador, I think. But she had gotten infected when she was a young girl, and she came in with full-blown congestive heart failure and ended up being Chagas disease. Okay? Uncontrolled tachycardia is sometimes will induce this as well. Duchenne's muscular dystrophy, these are all secondary effects. Chemotherapy drugs, and sometimes radiation therapy as well. Treatment of dilated cardiomyopathy is pretty supportive. Similar to congestive heart failure, so you treat it pretty much the same way. We preload reduce these people aggressively, so usually we'll give them diuretics pretty early, and then give them inotropic support as you need to. These people are at much higher risk for embolization, okay? Because when the ventricle begins to dilate, velocity drops off, and when velocity drops off means that the blood becomes stagnant. So there's much more incidence of developing thrombus formation. Antiarrhythmic therapy is also critical because a lot of these people will go into significant arrhythmias, and the principal reason for cardiac transplantation is dilated cardiomyopathies. Chagas disease is a disease endemic to Central and South America. This is where I lived for about 16 years of my life. One of the things that I was taught as a little boy was never to sleep underneath a thatched roof. Okay? It was okay to play underneath a thatched roof, I was taught, but never to sleep in it. And I was told if I do have to sleep in it, and I still remember this to this day, and I still sleep that way to this day, is you sleep with your face down. And you never sleep with your face up. And I didn't know why I was being taught all this stuff. It ends up being that if you sleep in these areas and you sleep underneath the thatched roof, there's a retidiform bug that actually lives up inside the thatch. Okay? And those bugs can actually become infected with a parasite called Chagas, which is a rickettsial parasite. Okay? And when it defecates at night, when it feeds, if your mouth is open, that defecating material goes into your mouth. And then you swallow it, and then you become infected with this disease process. And unfortunately, it's quiet, so you don't know that you have it until you develop problems 20 years down the road. Okay? What this basically does is this is the bug. Okay? This is the retidiform bug. Okay? And then once it gets into your system, the parasite will then perforate through your intestinal tract and basically embed everywhere in your body, specifically in your muscles. Okay? And it actually attacks the heart. Okay? It goes into the cardiac muscle and begins to damage the heart so much so that you get a hugely dilated heart that looks like this. This is on a 24-year-old person. Not a good thing. Okay? So this person will say got infected when they were 4 or 5 years old. Okay? It took that long before the symptoms actually appeared. In Central and South America, this is a huge problem in the sense that there's not much you can do for these people except to do a transplant. And you know the ability to do a transplant somebody is pretty low. In Brazil, it became such a big issue because you're in the rainforest. The incidence of having these kind of bugs is very high in warm environments, high humidity environments. And if they would just change their way, they didn't have thatch over them, they would be fine. They wouldn't have that ability for that bug to live in there. So if you live down there, it's okay. It's very safe. You go to a hotel, it's very safe. There's no problems. You're not going to have the bugs walking on you and causing this problem with you. So it's safe. I live there, and I never worried about this, and not many people do. But people that are actually living out out in the field or in the little towns, and they still have thatch huts, those are the people that are at risk. Anyways, what I was trying to tell you is that these kind of symptoms become so symptomatic in 24 to 30-year-olds that most of the doctors felt that they needed to do something, not let just these people continually die. So the Brazilians did something very brave, I thought, and they actually took these people and they did what's called ventricular re-architecture surgery. Okay? They went in there, did open heart surgery, put them on bypass, and then they cut the ventricle and remodeled it. So in other words, they cut a big portion of it and made the heart smaller. Okay? And actually, these patients really did well initially. Rejection fractions went way up because they're on the better portion of the starting curve. So instead of they being at 10%, they were up to 30%. They became better lifestyle. And they didn't require any immunosuppressive therapy or anything, so they thought they had a cure. Unfortunately, 9 months down the road, every single one of them had died. Okay, that they did a study on. So initially it was really touted as a big success, but what unfortunately happened was that all these people developed malignant arrhythmias. So they go into VTAC and VFib. So can't re-cure it that way. So again, we're back to the drawing board, how to stop this disease process. You will see this because we do have an immigrant population that comes in the United States. So you are going to see this disease process if you live here in Florida or you actually live anywhere in the United States. So just something to consider, especially people that are coming in that are congestive heart failure, that are young. Just keep that in the back of your mind. Okay? Pericardium cardiomyopathy is rare. Thank goodness, it's a dilated form of cardiomyopathy. I heard something very disturbing the other day. I heard that our rate of death for women has actually gone up. It used to be, I think it was 1 death a week of a woman dying from pregnancy. And I just heard yesterday, I'm not sure if this is being an inflated number, but they said we actually lose 2 women a day from complications of delivery. That seems like a high number to me, but that's what they actually were saying on TV. I was like, okay, we go read that study and find out if that's actually true. Okay, but it could be that for different reasons. Okay, what's happening, unfortunately, with our population in the peripartal stage is that our women tend to have our children later in life, which increases the risk of having concomitant cardiac disease. Also, women are actually also becoming much more heavy at the time of delivery than I've ever seen before. Our limit used to be that we would not put an epidural in anybody that weighed more than 100 kilos. That's when I first started here 17 years ago. We stopped doing that seven to 8 years ago because we were having almost everybody was above 100 kilos. 70% of our patients that are coming through the door are over 100 kilos now. And actually a lot of times we're about 130 to 140 kilos. So it makes our complication rates go up. Okay? It is amazing. You'll be surprised. When you do OB, you're going to go like, wow, okay, that's really impressive. And because you're going to have to be putting an epidural on these people. It's rather difficult. Okay? Risk factors, of course, is obesity, multiparity, advanced maternal age, multifetal pregnancy. Okay? When women have more than 2 babies in them, there's much more risk. Okay? If you're going to have sextuplets or something like that, that's really, you're asking for it. Okay? Preeclampsia also may be very closely associated. And African Americans also have a higher risk associated with this as well. It could be for 2 reasons. One is that they have a higher incidence of hypertensive disease processes, and the other reason possibly is due to poor maternal care at times. Okay? But I think a lot of it is related to overlying hypertension that you see in that population. Enlargement of the left ventricle due to the dilated cardiomyopathy can cause significant effects in the sense that you begin to impair the cardiac output to the baby, and as a consequence, the baby develops intrauterine growth retardation, as well as having problems with inadequate oxygenation to the baby. As a consequence, there's a higher risk of fetal demise in these kind of situations. Okay? What also makes the situation worse is that the time of delivery it's already a high risk profile because your cardiac output is pretty much at its highest point, but it's immediately postpartum when the baby is delivered and the placenta is removed that you get a massive preload return back to the heart, so the patient can actually go into failure immediately postpartum. Possible etiologies include viral cardiomyopathies, abnormal immune response to pregnancy, maladaptive responses to hemodynamic stresses. Patients develop severe dyspnea, fatigue, and peripheral edema. Okay. The secondary cardiomyopathies with restrictive physiology, here's what you see. You see a very infiltration of the cardiac muscle, like amyloid. You see amyloid deposition in the muscle. You may also get hemochromatosis, sarcoidosis, carcinoid syndrome. All these things basically infiltrate with these extra proteins or proteinaceous material, which then it basically acts like a restrictor and doesn't allow the ventricle to dilate properly. Things that you'll see is you'll see this kind of changes in the skin. Okay, the skin will abnormally change colors. Okay, and the same thing's happening inside the heart as well. Condition results in increased stiffness of the myocardium. You get impaired diastolic function, reduced ventricular compliance. Systolic function still seems adequate usually, and there's no cardiomegaly. It can affect both ventricles. Symptoms and signs of left ventricular and right ventricular heart failure can subsequently ensue. Amyloidosis cardiomyopathy often presents with thromboembolic complications as well. There's also embedding of the amyloid into the vascular itself, so you get some disease process that affects the peripheral tone. Atrial fibrillation is also very common, and you can get significant cardiac conduction defects. Involved with cardiac conduction can lead to heart block and ventricular dysrhythmias. Treatment includes diuretics, but don't overdo it. Okay, atrial kick is critical for ventricular filling in this situation, and dysrhythmias are very common. Prognosis, unfortunately, tends to be poor. Acts like a tamponade effect, okay, even without tamponade, so this ventricle becomes increasingly very, very stiff. Okay? If you put positive pressure to this person, the actinase significantly get worse. The ventricle will collapse even more, and the stroke volume basically is fixed, so heart rate is critical in these people. They're not really able to dilate, just like a kid isn't. Okay? So you got to maintain adequate preload at all times, but if you impair the preload at all, you're going to be in big trouble in your hands. Okay? Okay. Cor pulmonale etiology is the next discussion. Cor pulmonale occurs in COPD, anything that increases pulmonary hypertension. And things like restrictive lung disease can also induce that. Respiratory insufficiency, which is central obesity syndrome, hypoventilation syndrome, also called the Ondine's curse. Idiopathic pulmonary hypertension may also cause cor pulmonale. It basically leads to a reduced right ventricular, basically increases right ventricular workload in the treatment of this is that, okay, etiology. I went to, okay, skip one. But anyways, what cor pulmonale ends up doing is that it increases the right ventricular workload, okay, because of increasing pulmonic systemic pressures, okay. So the right ventricle basically begins to have to hypertrophy to increase its actually volume into the lung. The lung itself doesn't become wet or anything like that. It actually stays dry. And the compliance, depending on the disease process, may actually be reduced in the lung. Okay, but under certain circumstances, if you have only isolated vasculature problems, you don't really have alterations in pulmonary compliance. Okay. So one of the things that you want to try to do is you want to try to ameliorate this afterload effect. So trying to treat the pulmonary hypertension, of course, is primary. If you can treat that first, and the ventricle stops remodeling. Okay? If it doesn't, if you can maintain a very high pulmonary artery pressures, the right ventricle begins to hypertrophy and become more fetal-like. Okay? It never becomes like the left ventricle in the sense it doesn't develop into a concentric hypertrophy, but it will hypertrophy considerably. Okay? Eventually, the right ventricle will fail, okay, and then it will begin to dilate. That's a really bad sign. And what these people die of is left ventricular output failure because they don't have any preload going to the left ventricle. Okay? So literally, the left ventricle dies from lack of volume. Okay? So what you want to do for cor pulmonale treatment is you want to reduce the workload by decreasing your pulmonary vascular resistance and decreasing your pulmonary artery pressures. Sometimes this can be done by supplementing, by giving additional oxygen via nasal cannula or some other form of oxygen therapy. Sometimes we actually will do what's called a tracheal oxygen therapy. We actually will insert like a tracheostomy, which supplies oxygen more directly into the trachea. And you want to maintain saturations, of course, greater than 90%, which helps prevent the HPV from kicking in. The other thing that also is very helpful is that hypercarbia makes this worse as well. So you don't want to have hypercarbia. Okay? So preventing hypercarbia, that's why the central obesity syndrome causes this. Central obesity syndrome causes a hypercarbic chronic long-term effect, which causes pulmonary hypertension. So if you can decrease your CO2 levels, that makes the situation better. Diuretics and digitalis have been used in the past. You've got to be really careful with giving too much diuretics because what this person will suffer is left ventricular failure from inadequate volume. Okay. Transplantation of one or both lungs, so it's a heart-lung transplant, will sometimes make a dramatic relief of cardiovascular symptoms. Okay. The downside of torsives is you're going to be on chronic immunosuppressive therapy the rest of your life. Preoperative cor pulmonale is eliminating and controlling acute and chronic pulmonary infections, reverse bronchospasm, improving clearance of airway secretions, expanding collapsed or poorly ventilated alveoli. Hydration is important, and correcting any electrolyte imbalances. When you put these people to sleep, the biggest thing you have to worry about is making the pulmonary hypertension worse. Nitrous oxide may make pulmonary hypertension worse if you exceed 50% nitrous oxide. Okay, but under most circumstances, if you stay below 50%, which helps you, doesn't have a problem. Okay? If you hyperventilate the patient, it doesn't hurt. Okay? If you hypoventilate, then this is a person that you don't want to do this to. So when you want this person to be emerged and extubated at the end of the case, this is one that you want to really let the machine help you ventilate the patient off all the gases. Don't let the CO2 build up because that actually will make the symptoms worse. Okay? The other thing you got to watch for is you want to make sure that you don't develop hypoxia, as this also will hit the HPV up and make the pulmonary hypertension even worse and may actually induce a significant right ventricular failure that's very quick. The way you pick this up is look at the neck veins. If you see that you're hypoventilating and the neck veins get all of a sudden grossly distended, it means that the right ventricle is failing on you and you need to stop doing what you're doing. Is it safe to do under regional anesthesia? Yes, the answer is. It seems to work okay. The thing to be very careful with is that your left ventricle is very empty at that point, and if you preload reduce them too rapidly, you can get a significant drop-off in the actual outflow to the left ventricle, and as a consequence, you can get immediate, almost like a cardiac arrest symptom. So spinal, relatively contraindicated, possibly. Epidural, if dosed slowly, is okay. Just watch your volumes. Make sure that you're giving enough. Okay. Yes, sir. Nitric oxide is a great idea. It would also help relieve the pulmonary hypertension. That's what we actually use for ARDS situations, but in the operating room, we almost never have it available. You'd have to be in a specialized tertiary referral center that would have it in the unit. Okay? Most community hospitals don't have nitric oxides available. It's usually in major trauma centers that have it, that you can think about doing that. Not really. Doesn't really cause a problem. Remember, most anesthetics also vasodilate you too. They're pulmonary vasodilators, so that helps you already up front. So will nitric oxide give you better blood flow? Absolutely. Sometimes you actually will put catheters in the pulmonary artery itself and inject, what's the name of that stuff? Not dobutamine, what's the name of it? There's a vasodilator, pulmonary vasodilator. It's prostaglandin E is one of them. There's another one that also is being infused. What was the name of it? Viagra. That's not a bad idea, but I don't think it'll work most of the time. It will cause other problems as well. It can cause coronary steal syndromes and things like that. There's more selective things that we try to use now for the lung that also works as a vasodilator. So, okay.